Hello and a very warm welcome to today's webinar, which is Managing Discomfort, and a really important webinar. Lots of tips and strategies from our presenter today, who is Alex Holmes, and I'm your facilitator, Nicola Graham. So we start all our programs with an acknowledgement, and we acknowledge and pay respect to the traditional custodians, past and present, on whose lands we meet today. And we acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and respect the cultural authority of the elders in each community. Now I'll just get Alex to pop her webcam on as I introduce her. She can give you a little wave. And Alex is an OT. She works at Calvary Care, Bethlehem, working every day with clients who have a progressive neurological condition. Alex has been at Bethlehem for 2 years. She's also working at Epworth and Cabrini. And she's got a profound insight into the world of discomfort, and as I mentioned, some great tips and strategies and case studies to share with you today. So I'm going to turn my webcam off. I'm going to hand over to you now, Alex.
Good, thank you. So as Nicola said, my name is Alex, and first of all, hello to everyone out there and welcome. Thank you for attending the webinar today, and thanks to Nicola for this opportunity to present to you today. I hope you're all staying well during lockdown, if you're from Melbourne, that is, like myself. So as Nicola has said, I work at Calvary Care Bethlehem, and I moved to Melbourne about 10 years or so ago with my family. So today I'm going to talk to you about managing discomfort and provide you with some tips that I've learned along the way by working with this population. Hopefully by 4 p.m. this afternoon, you'll be feeling much more comfortable with managing progressive neurological diseases. So I'm just going to turn my web camera off before we dive into it. So the first slide. So first, just a quick note about what Bethlehem is. So Bethlehem is a public hospital in Melbourne, and we've temporarily located to the Bayside area while our new hospital at Caulfield site gets built. So if you're familiar with Melbourne, you probably might know where that is. So at Bethlehem, we've got a statewide progressive neurological disease service, which is the area I work in, and a community palliative care service, a ward in our hospital, and an NDIS specialist service, which is constantly growing. So the new hospital at Caulfield will provide an integrated model of care. So in addition to the existing services I've listed here on this slide, it's also going to have residential care and retirement apartments, a GP, radiology and pathology services. So I'm from the statewide progressive neurological disease service, a bit of a tongue twister there, which is a Victoria-wide outpatient clinic. So we manage people with progressive neurological disease all around Victoria, the border of New South Wales and Tasmania. So some of the services provided include neurological and palliative care, symptom management and neuropalliative rehabilitation and end-of-life care. So the main populations we see at Bethlehem are motor neuron disease, Huntington's disease, multiple systems atrophy, progressive supranuclear palsy, and some other rare neuro diseases. We do see some people with MS, but mostly these are now seen through the mainstream service. So you may have already seen the learning objectives already. And the main thing I'd like you to take away from today's presentation is to really challenge the way you think about discomfort and think beyond pain and pressure care. So I'm going to use a case study throughout the talk, which will highlight the key concepts, and I've included some poll questions as well. So later on in the session, we're going to be meeting John. So he's a man with motor neuron disease, and some issues that John has, you'll be able to generalize to other populations. So like, for example, the MS population. I won't be reading out all the contents on the slides, but I'll give you an overall concept as we go through. We'll keep it very informal, so if there's anything specific you want to ask, or if you'd like me to elaborate on anything, please send through the questions to Nicola. So first, I'd like to introduce a practice model we use at Bethlehem. So as you can see here, this is a neuropalliative rehabilitation model which we use. So it's a conceptual model developed in the UK to highlight the approach required for patients with progressive neuro conditions. So it describes the interface between neurology, rehabilitation, and palliative care. So you can see here on the left, this neurology, the circle here. So this is the diagnosis and ongoing management of symptoms throughout the disease course. So people with MND, for example, often go through a long diagnostic process. Moving over to rehabilitation. So this is about optimizing function and addressing their issues. So we mainly need to look at a compensatory approach. For example, you could suggest to someone that they use a wheelchair to assist when their legs are getting weaker, and they might use that as a form of mobility. So we use our neurology knowledge to inform this decision, as we know that rehabilitation to improve strength and balance is not going to be possible for this population. So therefore, we really need to compensate on their loss of function. And lastly, you can see here palliative care. So it's not necessarily about helping about when someone is actively dying. It's about managing a terminal disease over the last 6 to 12 months of their life. So this can involve things like symptom management of their pain, supporting the client, and also helping the family dealing with their death. So in the clinic where I work at Bethlehem, I commonly get people coming in to see me, and they report that they just can't get comfortable in their bed or their chair. And the more I've worked in this area, the more I've realized how complex pain and discomfort actually is. So it's not just about putting someone on a mattress or a pressure cushion. That really is just one piece of the puzzle. So it's important that we use a team approach and think beyond equipments for solutions. So we find often that by using positioning, medications, and psychological interventions together, this plays a large role in managing a person's discomfort. So today we're going to try and unpack a bit more about what could be going on for a person experiencing discomfort, and we'll be meeting John and his wife Emma later. Remember though that one size does not fit all, and by involving the multidisciplinary team, you get the best chance in helping our patients to be more comfortable. As a result of the COVID-19 pandemic that we're currently in, the majority of our appointments have now transitioned onto telehealth rather than face-to-face, and this poses its own challenges. Have a think now how this may have also impacted you and your practice. So now let's just take a step back for a moment and think about a time where you felt uncomfortable. For me, I can think of a few situations, even minor discomfort, like when you accidentally step on a plug or stabbing your toe off a corner surface. So I like to use the word discomfort as it describes more than just pain and pressure. There are many things that could be happening, as I've highlighted here on this slide. So when you ask your patients how they are feeling, they might describe it in many different ways. This picture here you can see with this guy is a little bit exaggerated, and your patients' faces might not quite look like this. But if we look at our patients' faces as well, that might give us some clues about what is going on for them. Other factors that can contribute to discomfort are things like spasticity, cramps, and psychosocial issues. So before we explore some different causes of discomfort, we're going to meet John, who is our case study for today. So John, he's a 47-year-old man with a rapidly progressing lumbar onset MND. So his onset of symptoms was about 12 months ago. He's also got a history of depression and anxiety. So I'm going to assume here a little bit of knowledge about MND, and I do have some references at the end if you'd like to have a read about it. In a nutshell, MND is a rapidly progressing neurological disease with no cure, and it's terminal. So each day in Australia, 2 people are diagnosed with MND and 2 people die from MND. More than 2,000 people in Australia at the moment have MND, and people tend to live for about 2 to 5 years with the disease. So what happens is it targets the motor neurons, which support the skeletal muscles of the body, which are responsible for moving your limbs, so things like your arms and your legs. The diaphragmatic muscles, which support your breathing, and your muscles for speech and swallowing. Ultimately, the person dies from respiratory failure, so it certainly can have quite a debilitating effect on the person. So back to John now. So he lives with his wife Emma and their 2 teenage sons in rural Victoria. So he attends our clinic at Bethlehem on average every 3 months, and he generally comes in for face-to-face appointments. Being a young male, the diagnosis has come as quite a shock to him, which we do commonly see with the patients that come into our clinic. He's been resistive to advice so far about aids and equipment, which you can understand to some degree as well. And I've been involved with John since his diagnosis was confirmed 9 months ago. And you can definitely see he's progressing with his disease. So walking has become more effortful and fatiguing, and as a result, he's had some falls. So he comes into our clinic for his appointments, and he's reporting he's uncomfortable in his bed. So before we go any further, just have a think about what could be contributing to John's discomfort in bed. So we see John in clinic and we try to get a better understanding of his discomfort in bed. So he's sleeping beside his wife Emma in a standard queen mattress and base. His greater trochanter is digging into the mattress, causing pressure and discomfort for him. He's also had some loss of weight due to muscle weakness in his mouth, and he's sleeping on his side. Fortunately, he's got no pressure areas, and he reports that his feet are feeling cold and that he feels like the blankets are weighing down his legs. He relies on Emma to assist him to roll in bed, and she's having to do this on average about 3 to 4 times overnight. However, this only eases the discomfort for John for a short time. John has also mentioned his pain and anxiety is impacting on his sleep, and as a result, he has little energy during the day to spend time with his wife and his sons. It's very important for John as well to remain sleeping in bed with his wife, and he feels it's a vital role for him as a husband and to also be able to maintain intimacy with his wife. So just have a think about now what you might recommend to John if you were his therapist, and we'll come back to that a little bit later on in the presentation. So that leads us on to our first poll question, Nicola. What factors might be making John uncomfortable in his bed?
Thanks, Alex. So I've just launched the poll and I can see that people are already voting. So if you could select one of the options from the poll that's just been launched, that would be great. I can see that over 70% of people have already voted. So I'm just going to give you a couple more moments to make your selection, and then I'll close the poll. Okay, that's great. And it's anonymous, guys, so we can't see who's given what answers. So feel free, be bold. And nearly everybody's voted, just a couple more people to go. So that's great. Okay. All right, I'm going to close the poll and share that. And Alex, can you see that? I'm never sure whether a presenter can see it.
No, I can't, no.
Okay, well, a really easy one here. Everybody, which I've never seen before, 100% of people have put all of the above.
The above. Good job. I'm easing you into it. So
they get harder as they go on then, Alex, do they?
A little bit, make you think. So moving on. So let's just look at some of the contributing factors that may cause discomfort in our patients. So you really want to consider the client's ability to transfer and the inability for them to change position. So often we find clients stating they're uncomfortable, and once you dig deeper to find out why it is, it's often due to the fact that they just can't reposition themselves like they used to. So I'm conscious now, even sitting here in this chair only for a few moments, that I'm making so many slight adjustments to my posture. Have a think about your posture now too. And you're probably also making many slight adjustments and movements that you might not even be aware of. But now think about if you couldn't move and how that would make you feel. Certainly, being unable to move increases shear pressure and friction on the body, and it can also result in pressure injuries, which can be painful. So neuropathic pain, that's a common symptom, particularly in the MS population, and this is due to the damage of the neurons and the central nervous system that are firing incorrectly. So we don't actually see neuropathic pain as much for people with MND. If you think your patient has neuropathic pain, it's best to get their neurologist to have a look, as there's specific medications that can be used to target this neuropathic pain. So regular Panadol is not effective for this pain. They actually need an antidepressant medication for this. Spasticity is one we do see a bit of. So that's the overactive stretch reflex in the muscles that causes that feeling of pulling down on their joints. So with weakness, we can also get low tone, which causes the limbs to move away from the joint by gravity. And then this, what happens is this causes traction on the joints. So you can see this through shoulder subluxation. Cramps, fasciculations, and constipation can be other causes of discomfort as well for a person. So what physical factors could be causing discomfort? So you can see here listed what I've listed on the slides. So contracture, muscle wasting, temperature changes. Also consider if they've got any comorbid conditions causing pain. So remember, a client might have MS, but they might also have arthritis, and their pain might not necessarily be to do with their neurological disease. People also just get back pain in the general population too. And think about how the person is sleeping. So say if you're used to sleeping on your tummy and then all of a sudden you can't, that can be uncomfortable then for the person. Also consider, have they had a fall recently? And this may have resulted in some bruises, which could be impacting on their comfort. So as you can see here, I've listed a long list of factors, which means we should not jump to conclusions if someone has pain. You really need to unpack this and understand the pain a bit more. So I'll just talk a bit about pressure care now, as it's an important area for us. So if you're not familiar with the Pan-Pacific Guidelines on Prevention and Management of Pressure Injuries, it's a great document. So it goes through assessment and management options, and then it includes aspects of equipment to consider. It's a very long document, but it's definitely worth a read. So I put a reference for this at the bottom of the slides. We know that preventing pressure injuries in our clients is the best approach, because once they develop a pressure injury, it's difficult to heal and the skin integrity is just never the same. So we should be doing a screen, such as like the Braden scale, and this is a good tool to determine their level of risk. Be mindful though that as the disease progresses, their function will change and you will need to reassess this down the track. Pressure care is such a large area and could really be a presentation on its own, so I'll just touch on it briefly this afternoon. So as you can see here on this slide, so the red triangles are the bony prominences that are in contact with the surface in sitting and in lying. So ones that you might not have thought of are the tops of the toes, which could happen from blankets or compression stockings. If the person is sleeping on their side, perhaps their ear, or if a client is using a ventilator, this can also lead to pressure on the bridge of the nose. So just keeping those things in the back of your mind as well. The pressure, as we know, on the skin can result in pain and discomfort, and prevention is vital for maintaining the comfort and quality of life for our patients. So this chart here that you can see on the screen, so this is taken from the Pan-Pacific Guidelines, and it highlights the different factors that impact on the risk of developing a pressure injury. So you can see here it breaks it down into tissue tolerance and pressure. So if you think about the disease your patient might have, it gives you a good sense of factors that might increase their risk. So generally, people with MND have an increased risk of developing a pressure injury due to extrinsic factors. So these ones here you can see listed. So things like moisture, so think like urine, feces, perspiration may soften the skin, making it more susceptible to pressure injuries. Shear, this is a tricky one I always find to define, but it is, if you can visualize it, it's the force where the two tissues are moving in two different directions. So commonly you will see this in a hospital bed. So if a person is sleeping with the head up and they start to slide down the bed, what happens is their skin will stick to the bed, but the rest of their soft tissue and skeletal is going the other way. So this then causes the blood vessels to occlude, affects the blood supply, and then of course can result in skin breakdown. So by using a knee break in an electric bed, it can reduce the risk of a person slipping down the bed and shear occurring. So generally you would see shear and friction together, and it tends to happen on the sacrum and the heels. So if our patients must stay in a bed, chair or wheelchair for a prolonged period of time, their risk of developing a pressure injury can be extremely high. Think about then if they can't change position without help, their risk of course increases. So approximately 15% of people with MS will develop a pressure injury. So just think about the MS population and you might get a sense of risk factors for these patients. So impaired mobility, impaired activity, and impaired sensory perception. So they can't feel what is going on. So they can't really feel that increased pressure. In addition, they might also have some moisture issues and continence issues. Perhaps some shear and friction is also occurring with the way they're doing transfers or the way they're sleeping in bed. So they're just some important things to keep in the back of your mind. Interestingly, though, people with MND don't generally develop severe pressure injuries as they have intact sensation and they can feel what is going on. So generally what will happen is they'll ask a carer to move them and reposition them. So that leads us on to the next poll question. So what factors might be contributing to John's risk of a pressure injury?
Thanks, Alex. I'll just launch this next poll. If people again could just select one option from the choices here, that's great. Okay. People are a little bit slower voting this time, Alex, so definitely your polls are getting harder.
So this question is meant to be challenging, and it's this just might want to make you think about what could potentially be going on.
Yeah, people are definitely having to think about this one.
Having you think on a Thursday afternoon.
That's right. It's nearly Friday.
Yes.
Okay, guys. Only half the people have voted, so the brains are having to work here, and we've got a bit of a rush on at the end now. So I'm just going to wait for the last few people to vote, and then I'll close this and we'll share the results.
And then I'll talk through it.
Okay, beautiful. Okay, I'm going to close this now. So we've got nearly 90% of people have voted, so that's terrific. And I'm just going to share the results there. So as you can't see, Alex, we've got 42% have taken the impaired mobility, impaired sensation, shear and friction option, 11% impaired mobility, moisture, impaired sensation, 44%, so the highest, have gone for the third option, impaired mobility, nutrition, shear and friction, and only 3% impaired sensation, nutrition and moisture.
Okay, so the answer here is C. So impaired mobility, nutrition, shear and friction. So with John's difficulty with eating, potentially his nutritional intake would be putting him at risk. So we could work closely here with the dietitian to see if they could help him improve his nutritional intake. We also know he's got impaired mobility, and perhaps shear and friction could be occurring for him with transfers. So other potential factors that could make John at risk of a pressure injury that I haven't listed on here would be things like moisture and if he's got any incontinence issues. So I suppose what makes it different from the rest of the answers was the impaired sensation. So this man has MND and generally their sensation is intact. So we'll move on now to the next part. So hopefully you've had a bit of a chance to think about what we might suggest for John if he was your patient. So I'll just recap. So he was having trouble moving around and repositioning in bed, and Emma was needing to help him with this. He said his feet are cold and he feels like the blankets are weighing him down, also making it difficult for him to move around in bed. It's also very important for John to remain sleeping in bed beside his wife. So ultimately what we're trying to do is to improve John's independence in bed as well as make it easier for his wife to help him. So a satin sheet with a satin, or a sheet with a satin insert, and I'll show you a picture of this a bit later on, basically can help reduce friction on the bed and make it easier for a person to move around. A satin sheet and a bed stick work quite well together and can make a big difference to a person's bed mobility. We also know his hips are quite bony, so you could trial a memory foam overlay, which could help redistribute the pressure away from his bony areas. Perhaps their bed cradle as well, so this would lift the blankets off his feet, and you can see that in the top left photo. You might also suggest that he could try wearing some fluffy socks to try and keep his feet warm. It's also important as well to educate John and Emma about prevention of pressure injuries, like doing things like skin checks. And I think educating Emma around safe manual handling techniques as well. So we know a bed stick and a satin sheet will work for the moment and keep John in his bed, his own bed, as long as possible, as that was his wish to continue sleeping beside his wife. However, it's important as well to plant the seed about the option of an electric bed, because we know as things will get more difficult with the disease progression. So I generally will refer to a hospital bed as an electrical bed or electrical control bed. As you can find, the stigma attached with the hospital bed is often a barrier as to why a person will accept one. So as John is on the NDIS, we could perhaps look at a more aesthetically pleasing 3-function electric bed, so something like an eye care bed or a Pliga bed. And I think it's important that we let John and Emma know their options. Also as well, reassure them that companion beds can be used that can be pushed up beside John's electric bed so that they can continue to sleep beside each other, because we know this was a very important thing for them as a couple. Could also discuss a referral to clinical psychology for ongoing support with adjustment to the disease and acceptance in his changing function. This may then help him accept other equipment needs in the future. Dietetics and a speech pathology referral would also be useful, as this could help manage his nutrition and his eating. So John's left the clinic appointment now, and we'll catch up with him a little bit later on in the presentation. So I've just listed here some psychological factors to consider when impacting on a person's discomfort. We all know if you've had a bad sleep, well, I know this myself, you just don't cope as well. And the same goes for our patients. Think about if they're not sleeping and they're feeling depressed, along those factors, along with the other ones here that I've listed in the slide, can really impact on how a person perceives comfort. I've just listed some extra ones that you might not have considered. So the stigma of disability equipment, particularly we see this at Bethlehem for a younger person. You know, they might not want to be using a walker. Also consider the equipment like a hospital bed on a person's relationship and their sexuality. So we've seen this with John and Emma in the case study. And if they have difficulty communicating their needs, this can of course be distressing for them and their loved ones. We also know that our clients will have some cognitive changes, and then this can also affect how they will perceive discomfort as well. So lots of things could be happening for your clients. So what do we do now? How do we actually get to the bottom of this? Discomfort as well is such a subjective area. We really need to talk to the patient and their carers and get a real sense about what is going on for them. So thinking about how do they describe their discomfort? What are they doing when it happens? Where is the pain or discomfort? How long does it go for? Is there anything that might help relieve the discomfort, or what are some of the factors that might hinder or flare it up? I think it's important to really get a sense of what people are actually doing and their daily routine. So as therapists, we've got great skills in observing people. So you want to consider things like their posture and how they're sitting in their chair or perhaps lying in their bed, and also how they're using equipment as well. Consider as well if they've got carers involved, how they might be doing transfers. As I'm sure some of you might have seen, and I have myself, where carers pull people up by their arms, and we know it's not good for the shoulder and of course can lead to pain as well. So hopefully now that will have given us some tips about what could potentially be causing the person's discomfort. This then can help us form a plan about what we're going to do. So when you have a plan, you want to evaluate what you're doing and also consider how this will be reviewed again in the future. Because we're dealing with progressive neurological diseases, we know their function is going to change over time. So whether this is 2 years from now or perhaps a few months from now, we really need to be thinking about how we evaluate this and what we're going to be doing with them down the track. Of course, making sure we involve our multidisciplinary team as well, so everyone can get involved and help manage the person's discomfort. So at Bethlehem, we're very lucky. We've got a large multidisciplinary team at our disposal. So we find by involving lots of different disciplines can really help manage a person's discomfort. So just think about the team where you work and what disciplines may be able to help you with managing your patient's discomfort. So we're back to John now. So it's been 3 months and a lot has been happening behind the scenes. So he's got a PEG tube, which is a type of feeding tube, and an NIV, which is a ventilator that he's using overnight. So these two is a good indication that his disease has progressed since we've last seen him. He's also continued to lose weight and his mobility has declined. So he finds walking and moving around a lot more challenging and effortful for him. However, he did agree to some of the equipment that we recommended last time, which was great. So the bed stick, the bed cradle, and the other few things that I mentioned. We know that he's now standing with assistance from Emma, and he's using his wheelie walker. He can now manage only taking a few steps, and he's relying on a wheelchair for longer distances. So he's sitting in the electric lift recliner during the day, which does not offer him great support. So he's slumping to the side and his posture isn't great. And we also know that he's now experiencing some hand weakness. So the team has handed over before John has physically come back into his OT session that John reports he's feeling uncomfortable in his bed and his recliner, and that his wife Emma is now experiencing some back pain. So we'd start to think that maybe his wife is getting some back pain as a result of helping John with his transfers. So we now see John in clinic and we observe that he's having trouble projecting his voice. So we can only imagine at night time when he's wearing his ventilator that he would have difficulty calling out to Emma. He's also needing assistance from his wife with transfers due to his hand weakness. So using the bed stick is becoming more challenging for him. He's also getting some cramps and spasticity in his legs at night. He finds the memory foam overlay comfortable, and he's now sleeping on his back with his head up and is using the ventilator overnight. So we're also thinking in the back of our minds that his usual sleeping position has now changed. So instead of sleeping on his side, he's now sleeping on his back. We also know that John has had a fall overnight that shows his mobility is declining and is a good indicator that perhaps he's coming off his feet soon. And because of the deteriorating function in his hands, John is also finding it difficult now to access his phone and his tablet, which is very important for him to being able to stay connected with his family and his friends. He's also reporting that he's got a sore bottom in his recliner. So we observe this a bit further, and we see a non-blanching red area on John's sacrum with some superficial skin loss, which what appears to be is blisters. So there's currently no dressings in place, and they also told us that the wound is not being checked by or monitored by the local team. So that, of course, is a bit of a worry. So based on the information I have given you, can you think about what stage pressure injury John has, which will then lead us into the next poll question.
Thanks, Alex. So I've just launched that poll for people to vote on, which is great. And people are voting on that nice and fast. So that's super. Thanks, guys.
Thank you.
Okay, so we've got just 70% of people have voted now, so I'm just going to wait a few more moments and close the poll and share that. Okay, great. So we've got just over 80% of people have voted, so I'm just going to close now and share the results. So we've got 26% of people saying stage 1, 58% saying stage 2, 16% saying stage 3, and nobody indicating stage 4 or unstageable.
Okay, so the answer here with this one is stage 2. So B was the correct response. So I'll just show you here the pressure injury classification system. So this is taken from Wounds Australia. So as you can see, it breaks down each pressure injury to its different stages, and it describes a description. It has a description and a visual as well. So stage 2 for John is partial thickness skin loss. So it presents like a pop blister, which you can see through shear and friction over an area. So we know John is sleeping in the bed with his head up. So we're thinking in the back of our minds that maybe he's sliding down the bed, and this could be how it's occurring. And we also know he's sitting poorly in his recliner and is sitting for a long period of time in that chair during the day. So there's a lot of detail here on this slide, and you can see it there for yourself. So you can have a look at this a bit further in your own time. I've also put a reference for it at the bottom of the presentation. So we'll come back to what we recommended for John a little bit later, but first we're just going to look at some strategies and equipment that we can put in place to have our clients more comfortable. So as we know, reduced mobility and the inability to move can lead to discomfort. So we really want to try and optimize the person's independence with their mobility. So it could be something like being able to shift themselves in a chair or in their wheelchair or their bed. So even ever so slightly can make such a big difference on their comfort and of course their pressure care regime. Another important thing to consider that can often be overlooked, as there's so many things that could be happening for our patients, is access to their core bell. So particularly the progressive neurological patients who lose the ability to use their hands independently, and also their speech can be impacted. Being able to get attention and call for help is so important. So you want to think about their daily routine as well, and also have a repositioning plan in place if they can't reposition themselves. So you might suggest maybe that they go back to bed for a rest during the day to offload from their sacrum. And you could also work with the physios on passive joint ranging and shoulder care and positioning. And then I think it's also important to educate carers also on correct positioning of limbs and shoulder care also. So let's just have a bit of a stretch now, because we've been sitting here in this position for a while. How nice is it to be able to stretch yourself when you haven't moved for the last half an hour? So think about our patients who are stuck in the same position for a while and rely on others to move them. So just by doing gentle stretches and gentle ranging of the limbs can really help them how they're feeling. It's also important to educate educate carers around transfer technique and thinking about their psychological factors as well. So relaxation and music therapy could help them with managing their pain. So we have access to music therapists at Bethlehem, which is a great resource to have. We often find a lot of our patients really benefit from it. So although we'd love to get rid of our patients' pain, sometimes their pain is chronic, and the reality is we just can't take it away fully, particularly neuropathic pain. But we really need to help our patients manage and live with this pain. So working with the multidisciplinary team is very important, and including the neurologist as well around medication management. It's really amazing how many people are so resistant to taking pain medications and will often need encouragement, even to take medications such as Panadol. So we find by using equipment, strategies and pain medications together can make such a big difference with managing a person's discomfort. You also want to think about if your client is wearing a ventilator. This might give you a little bit of a clue here about John as well. And if they can't use their hands, how are they managing to remove the mask during the night? So you can think about adapting the mask so they can remove it themselves. So thinking about maybe getting a quick release strap so that they can take the mask off when they feel like it. I think it's important to just give people back control where possible, as it can really make a big difference about how they are feeling. So I've got a couple of slides here now with some tips and advice that I've learned by working at Bethlehem and alongside a very experienced team there. So especially with the MND population, it's such a juggle with managing equipment and their changing issues. With John, for example, a bed sit might work for now with transfers, but we know in the future that a hospital bed and a hoist is ultimately what he will need. So we're constantly trying to anticipate needs now and anticipating the needs in the future and being one step ahead. Particularly now with the NDIS as well, and putting plans together and funding systems that have waiting lists. Really useful if you can think ahead about what might be important for your patient. You also want to consider the impact of equipment that you're recommending on their routine as well. So for example, you might put someone on an air pressure mattress on their bed, but now the surface is unstable and it might be challenging for them to stand up from the bed to do transfers. So just thinking about that whole setup and routine as well. You also really want to set realistic goals and expectations about what the equipment is going to do. So an air pressure mattress might alleviate some discomfort if someone has pain from, say, spasticity or neuropathic pain, but it won't be a magic solution to get rid of their pain. So I guess we just need to be honest with our patients around what the equipment is actually going to do. You also want to consider cognitive impairment, as this can impact on the ability to use equipment safely. So we know at least half the population with MND and MS will have some cognitive changes as well. So it's also keeping that in the back of your mind. There are so many different ways we can customize equipment these days. So I think it's important to take measurements, as brands will differ with dimensions. If you can, trial equipment and see what works best with your patient as well. Also, try and be creative and don't be afraid to try different things. So for example, if someone is getting pressure on their arm, say when they're sitting in the wheelchair, there's causing pressure from the armrests, maybe you could customize a piece of foam for them and tape it to the armrest. Sometimes we can be quite thrifty. Or do they actually need a customized piece of foam, a customized gel pad or a piece of foam? And a tip as well, it's always important to provide training to carers with personalized instructions with photos for setup and positioning. Because I find no matter how well you explain something to someone, there's an overload of information for these people. They've got a lot going on and people can forget once they've gone home. You also want to make sure that there's carryover between carers as well, so that they're all positioning and setting up the equipment in the correct way. So I've got some slides now on some aids and equipment options to consider. So specialized cushion and wedges. So things like neck cushions if a person has some neck weakness or neck pain. Perhaps a beanbag cushion to help position their limbs or support their trunk. So you can see here on the right hand side, this man is using a U-shaped cushion. So this is an excellent cushion that's actually sold in IKEA, and it's marketed as a breastfeeding pillow, but it's amazing for patients who have upper limb weakness and they just need their arms supported. It's quite a firm cushion. It's only $40, so good one to think in the back of your mind. And I'm not getting sponsored by IKEA. Memory foam as well. Maybe perhaps you could cut that to size, depending what you need, and consider any heel or side lying bed wedges. There's also a lot of different pressure care cushions on the market, which can be quite overwhelming, I'll admit. But just remember, something like a Roho, so that's an air-filled cushion, might be great for pressure and shear, but then it can make the person unstable if they're driving a powered wheelchair. And powered and manual wheelchairs as well can be really useful for clients who can't reposition themselves. So if they've got the tilt and space function. Also, a back recline is very good, but just be cautious with this. Depending on the person, it can impact on their posture, which means they can slide down the chair. Elevating leg rest, that's also a good option as well, particularly for managing edema management as well. But also just be mindful as well that if someone has tight hamstrings, what can happen is it can pull them forward in the chair and of course lead to poor posture. So electric lift recliners. So I tend to go for a dual motor recliner if I can, as it provides more positioning options for the person. Mattress overlays and pressure mattresses. So considering if you wanted a foam overlay, perhaps you want a mattress with a Roho insert. Do you need an alternating air overlay or perhaps a full replacement? Hospital beds as well can be fantastic in helping a person change position themselves by using the electric functions. So if someone is sleeping with the head up in bed, it's a good idea to advise them to use the knee brake, as this can stop them sliding down the bed, which then can reduce the risk of shear occurring. Also, I think it's important to consider their independence with the controls for the bed. So particularly if a person has weakness in their hands. So just a couple of things here that you might not have seen before. So the left one here, this is a cup holder. So if someone doesn't have the ability to lift the cup themselves, this could help with independent drinking. The middle picture here, so this is a switch adapted call bell, and you can get this through Technical Solutions. So this basically works like an internal doorbell. So it's a way of someone communicating with their loved ones or their carers as well. And the one on the right, so that's a scanning bed controller, also available from Technical Solutions. So if someone can't control the electric bed control themselves, if they've got hand weakness, you might consider this, where they can control the bed with a buddy button switch, so this red switch here in the middle. And it's really amazing, actually, once it's set up, that because the button can be positioned anywhere. So if they've got movement in their head, perhaps their feet, and then they can independently adjust the functions of the bed as well. So just giving them back that sense of independence and control as well. So here's some other examples of some equipment here. So we've got an air pressure mattress on the left, the top left. That's just one style of commode. The right one here, so that's a satin sheet, or a sheet with a satin insert, like I mentioned previously for John. Then we've got a hospital bed cradle down here on the bottom left, a bed stick, some Spenco heel booties, so just providing extra comfort to the person's heels. And that's just one type of hoist. So if a person's using a hoist, consider, do they need a mobile hoist or a ceiling hoist? And also think about what sling they're using as well, because that can really impact on a person's comfort, particularly if it's pulling up under the shoulders, like you can see with those slings that people use in the shower. So we'll just come back to John now. So what did we decide to do and recommend for him? So I'll just recap. So he was having trouble calling out to his wife overnight, which was of course distressing for him as he was stuck in the one position. And Emma was now needing to help him more with transfers, as using the bed stick was becoming more difficult. He's also had some falls, and we know that he has a stage 2 pressure injury on his sacrum. So a switch adapted call bell with a jelly bean switch and a clamp mount. So you can see that here pictured on the left-hand side at the bottom. So this can then make John being able to independently call for help as well. And that clamp can be positioned anywhere really where the person has reliable movement. You could also request that he has his NIV mask adapted for a quick release strap, so then he could remove his mask overnight as well, as this was causing him increased anxiety. Could also trial a hospital bed with the electric functions, so he'd be able to alter the height of the bed, raise the headbed up and use a knee break, which could help with his comfort and positioning in bed, but also make it easier for Emma to help him stand up as well and transfer. Perhaps we'd recommend a mobile hoist, so for transfers or in the event of a fall. So even suggesting to them if they start using the hoist at night when John is more tired. Because we need to remember our patients do fluctuate throughout the day with their function as well. Perhaps you can consider a mobile commode with a padded seat and a bedpan. Think about if you need a tilt and space option as well. So a commode would help reduce the number of transfers John needs to do, and also reduce the amount he needs to walk, therefore minimizing his falls risk and helping him with conserving energy. I think another important point would be to explore options to promote independence with using his phone and his tablet. So you want to think about positioning his tablet, so perhaps on a table, consider maybe if it needs to be mounted as well. And would a stylus work? So you can see one type of stylus here in the middle picture at the bottom. As we know, accessing his phone and his tablet was quite important to John, so it would be another area that would be worth exploring with him. Given he's got a stage 2 pressure injury, you try to limit the amount of time he's sitting in the recliner chair, as it does not support John's posture well. So it's also important to keep him off the area where the pressure injury is. So you could suggest maybe that perhaps he goes back to bed during the day to offload from the pressure injury. Also consider what type of mattress he is sleeping on as well. Perhaps you need to suggest, does he need a repositioning regime? And maybe consider some pillow or sideline wedges for when he's in bed. You could also trial a pressure cushion if he wants to get out of bed. However, I try and limit the amount of time he's sitting until his pressure area heals. If he does want to sit, however, you could explore the option of a tilt and space electric or manual wheelchair with a pressure cushion, as this would be preferable to his recliner chair, because we know it's just not offering him enough support. So a U-shaped cushion to support his arms in a recliner chair would also be useful. So you can just see here 2 pictures of U-shaped cushions being used. On the bottom right, so this is a satin sheet. So this is one that you can buy commercially. So it's from a company called Neki. And they've just developed this one here called the Wonder Sheet Plus, which is a fitted sheet that comes in different sizes for the bed. So as we know, satin sheets can help with bed mobility and helping a person reposition in bed also. However, they are quite pricey. So if a person doesn't have access to funding such as NDIS or a home care package, if they've got someone who's a bit handy on the sewing machine, sometimes we suggest that they sew a satin panel onto a sheet. So you can get satin from places like Spotlight or any of those craft shops, and it's a much cheaper option for them. So just moving on to the next poll question, how could optimizing John's independence with using his phone and tablet improve his comfort?
Thanks, Alex. So again, just inviting people to select one of the options below. And yes, people are voting quickly, which is fantastic. I'll just give you a few more moments. Thanks, Alex. So much information. It's really good.
Thank you. I'm conscious of time now as well, so I know people probably have work to get back to.
Okay, so over 80% of people have voted, so I'm going to close that poll and just share the results with everybody. So Alex, what people have we've got an easy one again. 100% of people have said all of the above.
Good, that's correct. So the answer here is E. So other benefits as well for John being able to use his phone and his tablet. So it would be things like to help with his communication. So using like text-to-speech apps, as this would be useful for when his voice fatigues. And I think then if he's relying on apps and technology for communication, it's also important then to consider low-tech options. As we know, high-tech options sometimes fail us, as technology does, and it can also be challenging for a person to use them in bed or perhaps in the shower. So just think about how we'd involve the multidisciplinary team and how you might hand over to them. So you could consider a referral to nursing for wound assessment and management, a dietetics review for nutrition to ensure optimal wound healing, medical staff to review pain and spasticity medications, a speech pathologist to help with the communication strategies and aids. I also think it's important for John to continue working with his psychologist to help him manage his anxiety. Also getting the physio involved to review spasticity, stretching and ranging for his limbs. And I think it's also quite important to link John and Emma here in with a social worker to help them with services and supports to reduce care burden for Emma. Because we know although Emma is John's main carer, she's also the mother of their 2 teenage kids, and of course it can be quite a juggle for her. So we've got another poll question. Perhaps we skip over this, Nicola, or you want to keep going? So the nurse rings us and asks us to arrange a pressure mattress for John. So what do we need to consider in our decision?
Sorry, Alex, I launched it and closed it and hid it, so we can't go back to doing that poll, so we'll skip over it.
Okay, we'll skip over that. So I'll just let you know the answer here is E. So you want to consider all these sorts of things if you're putting a pressure mattress on someone's bed. So thinking about how we'll support, thanks Nicola. So just thinking about how we'll support John moving forward into the terminal phase of his disease in conjunction with his local team in rural Victoria. So you want regular review and evaluation of his pressure injury management. So things like regular skin checks until the area has healed and stable. Medications also to help manage his symptoms, so they need to also be reviewed regularly. Ongoing team communication and care coordination, as there's lots of people involved with John. He's got the team at Bethlehem, and he's also got his local NDIS team. Also think about upgrading of equipment to anticipate need and monitor his acceptance for equipment as his disease progresses and ultimately his function is going to change. And be creative and resourceful. You might be able to make do and adapt equipment that he already has, and problem solve through these issues as his function changes. So I think a final point here is just to acknowledge the dignity of risk for John and also for your patients. So John might decide certain things he doesn't want, and as his therapist, it's important that we try and manage this risk as much as we can. So just some take-home messages, just a summary. So discomfort is a common issue for people with progressive neurological diseases, with many possible causes, as we have talked about today. So remember, discomfort is not always caused by pressure. So that's a key point that I'd like to get across. Thorough assessment is required to identify the cause of discomfort and ensure effective management strategies. Also very important to involve the multidisciplinary team as well in managing a person's discomfort. So generally, a combination of strategies is often required. So things like repositioning, equipment, and medications is often the most successful. Remember as well, progressive neurological diseases are a moving target. So we need to review regularly and be flexible as their needs will continue to change. So I've just put here some resources that you can have a look at in your own time. Some information about motor neuron disease as well. Some links to the some of the equipment I discussed, so like the satin sheet. And I'll just turn on my camera now.
Thank you so much, Alex. That was fantastic. So much useful information. And it's so apparent that discomfort is such a nuanced condition, if you like, and that our approach needs to be nuanced as well. And as you say, that discomfort is much more than pressure sores, isn't it?
Yes, yeah, and at Bethlehem, so you're welcome to contact the clinic here as well. So we do have a role in educating health professionals and providing secondary consultations. So we're more than happy to be contacted. It doesn't matter if your patient's not seen by our service, just feel free to give us a call or an email. So I put my own work number and my email in there if you want to get in touch, anything directed to the presentation today, or if it's anything more general, you feel free to call me, or if you want to call the OT department, I've left the OT department email there also. And thank you for your attention today. I hope it's been useful.
Alex, thank you so much. I have got a couple of questions, and
okay.
And thank you so much for letting people know that they can contact your service directly. I think that's really important, that people know they've got that support available. And
yes.
I have, before I get on to the first question, I've got some beautiful comments about your accent, and one is summed up really beautifully by Michael, who says, "Thanks so much, Alex, great presentation. My dog thinks you have a lovely voice, as he's been wandering around the room listening to you."
Oh, thank you.
I think that's a compliment.
Yeah, I didn't know I still had much of an accent. I've been here so long.
You don't sound Australian, Alex. Okay, so we've got a question here from Jane saying, it's not directly related to discomfort, but it's a really pertinent question, saying, any tips regarding helping people to accept equipment and or services, because we know people do tend to go to that default no space, don't they? So in your experience, anything you've found that can be useful to encourage people to accept those interventions?
Yeah, and I see this all the time, particularly at the beginning of a diagnosis when people are really adjusting to the disease. So what I tend to do is I'll show them equipment and say, oh, look, you know, these are the options available, and show them what the equipment does and explain to them their use. And then sometimes I'll even follow up with an email, send pictures of them and say, you know, if you want to get in touch with me, don't feel like you need to wait until like the next time I'm going to see you, that, you know, let me know over email if you want to use any of the equipment that I've suggested. And I also try and educate people on the use of equipment to help conserve energy, because we'll often find people will say, I don't want to sit down in the shower, like my legs are fine, but by them having a shower standing up, it exhausts them, and that's the only thing they can do for the day. So it's trying to, I suppose, educate them on other ways the equipment is helping them. So like, oh, if you sit down in the shower, say, for example, or you get some help from a family member, then you'll save that energy and ultimately be able to get on with the things that you enjoy most, because having a shower is boring. You know, you want to do the fun things that you enjoy doing. So I think it's just, and just like every time you see them, I suppose, you've got contact with them, that you remind them and mention the equipment again. Because people do forget when you show, especially if they're overwhelmed with a lot of things, you know. I think it's just trying to,
and I really like your
do the dance with them.
Yes, that's right. It is a dance, isn't it? And I really liked your tip as well, Alex, about educating carers and using the photographs and so forth, because people do get overwhelmed with information. Okay, we've run out of time, so I will close there. Thank you so much, Alex. I am just going to very quickly run through some final housekeeping very briefly. With here, so excuse me, I'm just going to. Thanks, Alex.
Thank you, everybody.
Okay. So just want to remind you of some of the services that we have here at MSL, which may be of benefit both to yourself and your clients. We have obviously education and a huge webinar library for clients, and a webinar library for health professionals to purchase recordings free for our clients. We have emotional support in terms of peer support. We do a lot of work on well-being for people living well with MS and other progressive neurologicals. We have a wonderful Australia-wide employment support service. We're active in the NDIS space, etc. So lots of services and supports. I encourage you to have a look at. There is a MS practice information that you can access from the website here. We are a registered NDIS provider with different services in different states. We've recently launched podcasts for clients, 20-minute interviews with experts on a range of subjects from sex and sexuality to bladder and bowel and support for carers, etc. So please have a look at our podcasts. You are eligible for free ebooks, and here's your username and password information. Again, as I mentioned, you can purchase recordings of previous webinars, and please do subscribe to Inform, which is where we provide information and research links about up and coming education. And we have our MS Connect service on 1800 042 138, where you can call for information as health professionals provided by our social workers, our MS experts, our nurse advisors, and you can pass the number on to your clients, where they can also have support regarding any question they might have related to their condition. And just got a few thank yous come in for you again, Alex. And again, thank you for your time. Really appreciate you listening today. And we know that the information Alex has kindly and generously shared with us will really go towards supporting your practice. So bye for now, and look forward to seeing you at future webinars.